Please join me in welcoming Dr. Sesso.
Thank you for that kind introduction, Cindy. And it's a pleasure to be here this morning. I appreciate everyone's willingness to come and hear sans liquids and hopefully caffeinated to the extent that you need to. So it's always fun to be here. I did this talk last year, and it was really good to hear a lot of the questions I was getting actually from all of you after it, because a lot of what you've heard thus far is focused on kind of supplements, definitions, some of the legal issues, marketing, labeling. But I'm coming in from a different perspective here. I'm a researcher, I'm an epidemiologist by training. I'm involved with a lot of the large-scale trials that have been conducted over the last decade or two looking at vitamin supplements and health. And there's always a question that comes up with all these trials about whether or not what we're getting out of these trials reflects either efficacy or effectiveness. So I'd like to kind of walk you through at least my take on these two terms, what they mean, as well as how they apply to the types of research that you might be conducting, and especially in the context of clinical trials. Okay, so we know that if you take the traditional roots of nutritional epidemiology, we've seen a consistent association between different foods and lower rates of cardiovascular disease, cancer, and many other chronic diseases. We see these studies come out all the time. And the challenge has always been, how do we translate these findings? And we also know that if you go beyond the foods and beyond the dietary patterns and start delving more into some of the specific vitamins, minerals, and other nutrients, that we see that there's a strong justification for this potential benefit. That's why a lot of us are in this room today. And what we've always asked as researchers is the simple question of, if the foods are good for you, are there specific components in those foods that might explain or drive this potential benefit or effect? And it inevitably, for better or for worse, evolves into a question of dietary supplements and what their role is. Can we somehow bottle or create a supplement that captures these benefits in a way that we can have meaningful improvements, not just in terms of health individually, but in terms of public health? Now, that might be a little too pie in the sky, but at the same time, it's extremely important to remember that we always want to continue to emphasize all the healthy dietary patterns. So it's always important to emphasize all the dietary patterns, but inevitably people still turn to supplements for many different reasons, which we'll start to walk through today. And what's always interesting is that when you hear about different kind of vitamins and minerals of the day and different dietary patterns, what tends to happen is that the dietary supplement use tends to increase ahead of the definitive clinical trials that help to really determine whether there is any degree of efficacy or effectiveness on those outcomes that people think that they're taking these supplements for and hoping to get benefits from. So I think one thing that we need to first do is just have an understanding of the distinction between efficacy and effectiveness. They sound similar, but they actually denote two different concepts when we think about the interpretation of studies and particularly clinical trials for dietary supplements. So when you think about a clinical trial, it could be done in one of two different ways. It could be done in a kind of a real-world setting where it's not as controlled. We're not monitoring patients quite as closely. And alternatively, it could be done in a more optimized environment, not necessarily treating subjects as lab rats per se, but having a much better sense of what people are taking, how they're taking it, and being able to capture and measure that very carefully over the course of a clinical trial. And this is a nice diagram that kind of asks two basic questions that you want to link with either efficacy or effectiveness. So if you're thinking about efficacy, you always think of efficacy as kind of the ideal, perfect world scenario. Can this treatment or this dietary supplement operate well or be beneficial under ideal circumstances? On the other hand, we know that in the real world, sometimes people take pills, sometimes people don't. Sometimes people are taking them all the time, they're taking twice as much or not as much. So effectiveness reflects the idea of whether or not a particular treatment, or in this case a dietary supplement, reflects ordinary or real-world circumstances. So I think this is one, as you can imagine, as we'll walk through this, there are strengths and weaknesses to each concept and how we either conduct the trial or interpret the results of a trial that's testing a dietary supplement. And if anything, my hope is that you'll walk away from my little piece here this morning being able to ask these questions when you read about different studies or if you're conducting the research yourself. So again, just to kind of reiterate this, when we think of efficacy trials, we're asking the question whether that treatment helps under ideal circumstances. And there's always particular aspects of efficacy trials that you want to highlight or look for if you're reading a paper or trying to design something. So first of all, do the patients or subjects accept the interventions that are offered to them? It's a basic question of compliance. So it's not just whether they're going to take those pills, but also are they going to follow the instructions faithfully and take those pills, whether it's daily, 2 times a day, 3 times a day, 4 pills, 1 pill, whatever the intervention might consist of. Efficacy trials also assume that you're getting the best possible care and you do not have care for other diseases. So it's always focused on the exposure of interest as well as the outcome that you're interested in that clinical trial. So most trials, if you're a trialist and you're trying to put, whether it's a small trial or a large trial, you're usually designing trials this way. You want it to be nicely controlled conditions. Everyone takes the intervention. Everyone takes the matching placebo. In reality, we know it's not that easy, depending on the type of trial and the study design that you conduct. So this is where effectiveness trials come in. And again, it's asking the question, does that treatment or dietary supplement in this case, or herbal, whatever you're testing, help under real-world circumstances? So now you're starting to introduce kind of the reality of conducting clinical trials, whether in a smaller setting or in a much wider setting. You've got the usual elements of patient care. You have differential access. Some subjects might not take their assignment. We want compliance to be 100%, but we can't necessarily guarantee that in the real world. It's no different than antihypertensive medications and other types of prescription medications that we give out in the doctor's office. People might take them, they might not. The key is to try and see if we can understand what that compliance is. Patients might also drop out of the study. Now, of course, this is a function of the type of trial. If you're doing a trial that might be 1 or 2 weeks long, it's a very carefully controlled environment, that might be less of an issue. But for the larger scale prevention trials, this becomes a greater issue with loss to follow-up. The other thing is that subjects are pretty creative. You'd be surprised how many ways that they can find the treatment that they were not assigned and take that instead. Many times, especially in trials of dietary supplements, if it's, say, a vitamin D trial, someone feels very strongly about taking vitamin D, they become uncomfortable with the idea of being randomly allocated to either take a vitamin D supplement or a placebo, they might just start going to the store and buying 1,000 IUs to take daily anyway. And then you have differential access to healthcare. So whether it's the doctors that you see, the facilities that you go to, and so the outcomes that you might be interested in a trial are harder to detect when you have issues of effectiveness. Sometimes what's called an MI in one part of the world could be different from another part of the world, or by a different treating physician. But ideally, in an effectiveness trial, you want to describe those results as most patients would experience them. So there's been many people actually define what we call the implementation gap. And this is the difference in the results that you would see had you conducted a trial under the optimal circumstances of efficacy versus the real world of effectiveness. Now, it's also kind of viewed as kind of the gap between ideal care and ordinary care, but I think the hard part with this is that you really never know exactly what that implementation gap consists of, because it's very difficult in most circumstances to create the quote-unquote perfect trial, right? Complete 100% compliance, no loss to follow-up, no issues with pill taking or whatever. Typically, you start with the efficacy trials. You try and create the ideal circumstance, the very protected fishbowl, and then try and translate that to a broader population in more usual care or effectiveness trials. And the assumption is that if a dietary supplement under the best circumstances has no impact on your outcome, then the likelihood of that extending into an effectiveness trial is probably quite low. In other words, if you control all the circumstances of that trial and you can't see an effect, or you see a lack of effect, to be able to suggest that you can lower your compliance, lower loss to follow-up, expect to see that same effect is actually quite low. At the same time, sometimes you'll start with the effectiveness trials, and when those are done first and they show no effect, you can argue that the lack of effect might be due to the fact that you didn't have the ideal circumstances, that maybe the lack of effect in that effectiveness trial might be attributable to the fact that compliance was low, or loss to follow-up was high, or other circumstances that start to cut away at the potential internal validity of that clinical trial. So it's often seen as a bit of an excuse, which I don't think is necessarily well warranted. But to me, if you see poor compliance in a trial in the first place, in what would be an effectiveness trial, that to me is usually a signal. You have to ask yourself, all right, well, why was compliance low? Was it something inherent in the study design? Maybe the study was just too long and it was just difficult to maintain it. But maybe there's side effects or other adverse effects that are associated with that supplement, or other medical events, other intermediate outcomes are happening along the way. So what's nice about dietary supplements is that in the context of clinical research, epidemiological research, and in trials, they're really well suited for the evaluation of both efficacy and or effectiveness. Most, not all, but most dietary supplements are very much amenable to placebo control. So you have a very clean comparison between treatment and control or active or placebo, excuse me. Most dietary interventions, especially with supplements, tend to be fairly simple. You're either taking a pill or a capsule or a tablet versus something that's the same but not the same. It doesn't have the active ingredients. So it's a very straightforward comparison. This is especially important in the context of dietary modification. There have been a lot of really important trials that have been done that involve, could be adhering to different types of dietary interventions, the Mediterranean diet, you name it. Those are very difficult to conduct, given the fact that you're not just changing things on the basis of a pill, but rather behavior. And it just involves a lot more effort. Not that it doesn't undermine, these trials are still extremely important, but they're just harder to conduct. And the other thing that's nice about dietary supplements is that they are very much conducive to large-scale trials. You don't have the same type of potential adverse effects that we believe are associated with those dietary supplements. So they're much more conducive to large-scale trials. Again, it's hard to achieve ideal efficacy, even in the dietary supplement trials that have been conducted. Compliance will never be 100%. You want it to be close, but it'll never be 100. There'll always be some degree of loss to follow-up. And it's always a bit of a slippery slope between efficacy and effectiveness. There's really no single demarcation line based on different specs of a trial, whether it's compliance or loss to follow-up or adverse events. There's no way to clearly distinguish between the two, but I think it's important to understand at what point do you think you might hit a threshold beyond which you can go beyond effectiveness and argue that you see efficacy for a particular dietary supplement. There's another consideration that's important to think about when we are trying to determine whether or not something might be a trial that's determining efficacy versus effectiveness. And these are data from the Physicians' Health Study, which is a trial that was initiated back in the 1980s that I'm now a part of in terms of a second iteration of this trial. And what this simple diagram captures is just because you've randomized 22,000 people into a trial, the representation of those people to the general population, no matter whether you're testing it in physicians or even a trial in a general population, also affects the degree to which you might be able to determine whether something is efficacious versus effective. So even though we've randomized 22,000 people into the trial, we had to start by mailing out questionnaires to more than 250,000 physicians around the country to even get them to the point where they can be randomized in. So by the time people decide they even want to return the questionnaire that we send, they're willing to be in the trial, they're eligible based on the criteria that we have, they get through a run-in phase where they can demonstrate consistent pill taking, and then they're randomized. This is not necessarily representative of the general population, so it's also difficult in clinical trials. It's important to keep in mind the volunteer bias or the selection that comes into play here too. And in fact, this selection has an impact on outcomes that you might be interested in. So if you were to look at either people, and this is a kind of a half-hearted joke that we often say when we do these trials, is that we want to encourage people to actually respond to the questionnaires that we send, because merely responding to the initial enrollment questionnaire, regardless of eligibility, your mortality rates are lower. Whether you're willing to be in the trial, you're going to have lower mortality rates. It's not just for total mortality, it's for cardiovascular and cancer mortality as well. And it's not surprisingly, by the time you get to those who are randomized, when you see the absolute age-adjusted mortality rates here at the very right of this graph, very, very different and much lower than where people started. So it's another consideration to think of, not just in terms of the design of the trials, but also in thinking about efficacy versus effectiveness. This is looking at it from a slightly different angle. So this is a meta-analysis that was published in BMJ earlier this year, looking at, I think it was behavioral interventions in diabetes. And this is, again, getting at the same idea from a different angle. This is when they were combining the data. These are all trials that were focused on pre-diabetic populations. So obviously, those who, you have the general population, but you get a smaller and smaller circle, smaller slice of that pie by the time you get people who are either randomized or who actually complete the trial. So when you're conducting these trials, whether they're particularly large or particularly small, they're all important, but the way to which you can generalize those findings in the context of that potential efficacy is something that also needs to be carefully considered. So study design also comes into play. You'd be very surprised, particularly in dietary supplement research, to the extent that the study design will impact how people will interpret something that might be seen as efficacious versus effective. This is not to belittle the importance of any of these studies. When we think about particular dietary supplements, we need a mechanism, we need to be able to demonstrate everything from the entire range of studies. But by and large, we usually would like to assume that clinical trials are at least toward the top of that heap if it's well conducted in terms of determining not just validity internally, hopefully with some external validity, but also hoping to identify some degree of efficacy with that dietary supplement. So shifting gears, one of the other challenges that we see with dietary supplement research is also trying to understand how the dietary factor gets translated to the supplement. And for no particular reason, I'm decided to pick on a strawberry, literally. If you think about it, so if there are studies that come out that suggest that strawberries might be beneficial in various health outcomes, we always are asking different questions. It could be the food, so maybe it's something about the food matrix. For the whole food people out there, that's the argument that they would take. The other argument could be that it could be a function of dietary patterns. People who eat strawberries are eating other components of a heart-healthy diet, and that might explain those benefits. It might be that there's something specific to the strawberry. Maybe it's the folic acid content, maybe it's the fiber content. Or it could be simply confounding, that there could be other factors that are related to strawberry intake that could otherwise explain those effects. And without wanting to completely rehash some of these points, because I know that a lot of this came out from the discussions from yesterday, dietary supplements, it's been a very interesting history if we see it, not just in terms of the history, but also looking at store shelves over time. They're occupying greater and greater chunks of our store shelves each year. And we know that the research had really kind of started to put the supplements onto the shelves back in the 1970s, and the question has always been whether those supplements provide equivalent benefits as the food source. And these data start from the basic science and observational studies, but these don't really have bearing on clinical efficacy or effectiveness. And so it's really the clinical trials that have ultimately been the judge of whether a lot of these dietary supplements do or do not have real effects on a lot of the health outcomes that have been of interest. And just as one example, the U.S. Preventive Services Task Force had put out a statement back in 2014 where they are, and this is a common issue, usually they'll say the evidence is insufficient. So this was in particular with regard to multivitamin, multimineral use. They came to the conclusion that current evidence is insufficient on the basis particularly of clinical trials. Lots of people take these supplements, but we have very few trials that necessarily see whether these potential benefits or risks might be real effects or not. So again, most people are taking them. They might help specific nutritional deficiencies or insufficiencies, but there still are perceived but unproven benefits. And whether that nutrient in the food is the same as the nutrient in the supplement is always an ongoing debate. Eventually, these nutrients are encapsulated, but this is where the clinical trials start to become helpful. And we always talk about the high rates of dietary supplement use in the United States, but it also extends out globally. It's kind of hard to read this at this hour in the morning, but the bottom line is, and this is a review that a postdoc of mine had conducted last year, it nicely summarizes the fact that while certainly the supplement use rates are highest in the United States, they're actually still quite high in other parts of the world as well. So this has not just national implications, but global implications too. So what typically happens when we do research for a dietary supplement? We always think that there's potential health benefits. And we start with these, especially these small-scale trials that start to show potential reductions between dietary supplements, related biomarkers, and mediators of chronic disease. So kind of getting at the mechanisms of effect. So it could be oxidative stress, inflammation, hyperglycemia, insulin resistance, you name it. Insert your favorite mechanism of effect there. Eventually, that starts to lead to some of the larger prospective cohort studies that will try and look to see whether dietary supplement use is also linked not just with the intermediate outcomes, but also looking at some of the harder clinical outcomes. And that could be type 2 diabetes, hypertension, hypercholesterolemia, some of the site-specific cancers, and other outcomes of interest. But the hard part has always been whether these observational studies really do demonstrate an efficacious effect. Are these observed findings real or not? We know that residual confounding, so explanations by other factors, come into play. The small-scale trials are certainly instructive, but those are usually getting at mechanism rather than looking at real outcomes that help to determine efficacy or effectiveness. We also know that people who take dietary supplements are inherently different in ways that we don't still fully comprehend. We know they tend to be older, they're women, they tend to have a healthier diet and have other beneficial lifestyle patterns broadly. They'll exercise more. And in some instances, they'll tend to be diagnosed with conditions. So sometimes dietary supplement use can be a bit reactionary. I just went to the doctor. My blood pressure was a little high. I was called prehypertensive. I don't want to start taking medications, so maybe I'll take some supplements that I believe that might reduce my blood pressure and make some other changes. And just because the cohort study is large, and this is kind of pointing to the nurses' health studies and the health profession and some of the other larger cohorts that are out there, the size of the study is nice, but that doesn't necessarily denote greater efficacy when you're trying to evaluate whether that dietary supplement has a real effect or not. And just to underscore some of the, I wouldn't quite call it a healthy user effect because it's not necessarily a healthy part of it. It's more of a user effect when we think about supplement use. These are data from the Physicians' Health Study where they had reported use of either multivitamins and other supplements or other supplements only. And you can see that there are distinct patterns, whether it's, older men tend to use supplements more frequently. They tend to be more frequently exercising vigorously. They're using aspirin, but they've also had a diagnosis of hypercholesterolemia. To a certain extent, hypertension as well, but they're also eating their fruits and vegetables. So it's a bit of a mixed bag when you think about the impact of residual confounding and who uses supplements when you're trying to interpret the findings in the literature, particularly from observational studies and the smaller cross-sectional studies on dietary supplements and health. And this is just as an example of one of the challenges of trying to interpret this. These are data from the Physicians' Health Study, observational data, in which we looked at the duration of multivitamin use and risk of cardiovascular disease. So, it looks like a very encouraging finding. It suggests that those men who are taking a multivitamin for more than 20 years, which is a long time, would suggest to have reductions fairly consistently in not just major cardiovascular events, but also some of the individual components of cardiovascular disease. The problem with this is that this is an observational study. So those men that are taking the multivitamin supplement for longer periods of time are going to be fundamentally different from those who are. We try to adjust for these things in the analysis, but in an observational study, you can't quite cut at all that residual confounding. So this is, again, where the trials become particularly important. Another example, this is looking at magnesium intake in type 2 diabetes. This is a meta-analysis that was done. So if you look at the forest plot, these are based on observational studies, so prospective cohort studies. Again, it's pretty strong, compelling evidence to suggest that those who consume greater amounts of magnesium intake might lower their risk of type 2 diabetes. But again, while promising, certainly should lead to more research. I'm not going to deny that. But yet, at the same time, it's important to think about how residual confounding might otherwise be cutting into these findings and to what extent. And then extending this into looking at vitamin D supplementation, if you were to look at circulating 25-hydroxy-D levels, combining results from different observational studies looking at cardiovascular disease, same type of question arises. Can these observational data rise to the level of either efficacy or effectiveness for vitamin D supplementation? I would argue that for the most part, it doesn't. And it doesn't mean that these are not important studies, but these are really meant to be hypothesis generating through which we can use the clinical trials to get at the real answers. So what are the typical dietary supplement trials? There might be a relatively short duration of treatment and follow-up. You're comparing versus placebo. It might be, as an example, postmenopausal women with prehypertension. You look at some different outcomes. Now, is this optimal to determine efficacy or effectiveness? Probably not, but if it's well conducted, you can start to get toward that end. And it's always important when you conduct these trials, either as a trialist or interpreting it in the literature, to ask to what extent we can take those conclusions from these smaller trials and extend them to some degree of effectiveness or efficacy. They tend to have good methodology. You'll tend to have pretty good compliance, right? If you're told to take something for 8 weeks, that's a different prospect than being told to take a supplement for 8 years. It really helps to get at the mechanism of effect, but you don't know how reproducible it might be and how generalizable it might be. And the lack of hard endpoints becomes problematic ultimately. Oops. And that's where the large-scale trials, albeit the challenges of conducting them and getting the funding and trying to get it coordinated, still have a very important role, particularly in the context of dietary supplements and efficacy. And one thing that's often missed out, because I think one would look at a lot of the large-scale trials of dietary supplements and argue that a lot of them have either find a lack of effect or even a potential risk, and some beneficial effects in there too. All the results from these trials tend to be informative, and they drive public health and policy. A lack of a null effect, yes, that means a lack of efficacy, but that tells people that there's no reason to necessarily be taking that supplement. If you see a benefit, then there might be potential efficacy, and that people should at least consider taking that supplement. It doesn't mean everyone should universally start taking it, but at least we know we're seeing greater evidence heading toward that kind of that zenith of efficacy, whatever you want to define that as. And if there's harm, we see a lack of efficacy that we now know that people should probably stop taking that supplement. And it's always important to consider the balance of risks and benefits with these trials. They tend not to just look at one endpoint, but many different endpoints. And despite what we see from these large-scale trials, people still tend to take the supplements. There's been a lot of trials that have looked at beta-carotene and vitamin C and vitamin E and others that have largely found a lack of effect, but people will still tend to take them because there's a belief that, oops, too much of a hand waver. There's a belief that it couldn't hurt. And based on the store shelves, knowing that they're just growing with more and more dietary supplements and herbals and other products from week to week, literally, we know that there will always be new supplements that will be coming out, that will be emerging, that we'll need to make sure that we test in some way, shape, or form. But I would argue that the clinical design is probably more important than the actual outcome that you get from that trial, because regardless of what you test, if you don't conduct that trial well and have the best methodology that you can put into it, it's going to undermine the extent to which you can make any claims for efficacy or effectiveness. And I just wanted to walk through a few examples of some of the types of trials that I've been involved with up in Boston. One is the Physicians Health Study 2. And this was a large, simple, I wouldn't quite say simple, but it's simple in design and conceptually of a randomized clinical trial in which it was conducted entirely by mail. And this is one thing that's nice about dietary supplements, is because you don't have the types of restrictions that you might have with prescription medications per se. You can do these mail-based trials of dietary supplements, not just very in a large scale, but also fairly cost effectively as well. In addition to doing the trial, we also were able to collect bloods in about 70% of the participants in this trial. We had nearly 15,000 men that were male physicians aged 15 up, and we tested a very common multivitamin at the time in the mid to late 1990s, Centrum Silver. We also, in this trial, had tested vitamin C, vitamin E, and beta-carotene, but I'm just going to focus on the multivitamin results for today. Our primary endpoints, because it's a larger trial, longer trial, clinical endpoints. So we looked at cardiovascular disease and cancer, and we had secondary endpoints that included eye disease and cognitive function. Now, compliance was not perfect. It was still decent. I would argue that 67% compliance to take a multivitamin daily for 11 years is actually pretty darn good. But it still raises the question of whether this is an efficacy trial or a trial of effectiveness. It depends on where you want to draw that line. Now, when we after all this time, when we looked at the results, we actually found that taking a daily multivitamin had no effect on one of the primary outcomes, which is major cardiovascular events. If we looked at some of the other components of cardiovascular disease, we saw a similar lack of effect. One thing you always have to be careful of is that when you see these individual things like MI death, a suggestion of a benefit, it's a suggestion, but when you see that in the context of all the other results, it was something that we thought was interesting, but certainly not anything that we're going to be hanging our hats on. We also had looked at the effect modifications. So what's nice about these clinical trials is that, especially the larger ones, is that you can start to slice the data carefully and in a pre-specified manner to see whether particular subgroups might benefit more from taking a particular dietary supplement versus others. And you have to be careful about this. In certain respects, to suggest that there's a one-size-fits-all capacity of a dietary supplement to work in everyone in this room, for example, is a bit of a misnomer. We know that, and this is where this notion of personalized medicine, personalized nutrition, how it's going to be defined over in the years to come, we'll see. We know that the results tend to be a bit more nuanced. And if we looked at the role of baseline age in the Physician's Health Study 2, what we saw is that there were at least some suggestions that older men might benefit a little bit more, although it wasn't a very strong effect. But in particular, what we had seen is that if you look at the cancer endpoint, there was a potential, it was a very modest but significant 8% reduction in the other co-primary endpoint of total cancer. If you kicked out prostate cancer, there was a lot of prostate cancer in the Physician's Health Study 2 because these were physicians going through the 1990s and 2000s when PSA screening was going through the roof. And about half of the cancer in the Physician's Health Study 2 was very early stage prostate cancer. So if you focus more on the true epithelial cell cancers, you actually saw an even stronger effect. What's interesting is that if you looked in the older men, there was an 18% reduction among those men aged 70 and up for the primary endpoint of total cancer. And one slide I don't have here is that if you actually isolated, there were about 1,500, wrong number, about 1,400, 1,500 men or so who came into the Physician's Health Study 2 coming in with a baseline history of cancer. In those men, we actually saw a 27% reduction in subsequent cancer among those men taking a multivitamin versus those taking placebo. So like any good trial, a good trial will answer your initial question that you have, but will come up with multiple questions after that that you still want to try and pursue. Another trial that's currently going on in our research group is the VITAL trial, the vitamin D and omega-3 trial. So this is testing vitamin D supplementation at 2,000 IUs daily versus placebo, and also looking at omega-3 fatty acids, essentially fish oil. It's about 1 gram a day with a mix of EPA and DHA. So this trial got started about 6 or 7 years ago now, and is actually coming to a close at the end of this year. So the randomized treatment and follow-up will be about 5 to 6 years on average. Will end at the end of this year, and our hope is that sometime next year we'll be coming out with those study results. But again, vitamin D is a nice example of a dietary supplement that's being used with an increasing number of people in the population. I feel like there's like a study a week that comes out that's praising its potential virtues, but yet there's very little trial evidence that has supported it, especially from the larger scale trials. And so VITAL will be an important step forward to try and have a better understanding of what the role is of vitamin D as well as fish oil on not just the primary endpoints of cardiovascular disease and cancer, but VITAL is a nice example of a clinical trial that built in a lot of different ancillary studies looking at other major endpoints as well as intermediate endpoints to try and delve further into the types of mechanisms that might be at play. And then finally, based on some of the results that we had seen from the Physicians' Health Study 2, we recently initiated what's called the COSMOS trial. And as you can imagine with these, you always have to have an acronym that sounds kind of cool. You can't just call it the BLA trial, because no one's going to be interested in that. But what's nice about COSMOS is that we had seen this potential effect of a multivitamin, particularly for cancer endpoints in the Physicians' Health Study 2, to which we extended it to this new trial called COSMOS. We're in the midst of recruitment for it. We've already randomized about 11,000 people. We'll eventually get to 18,000 people by the end of this year. And they'll be either taking a multivitamin or placebo, and then we're also testing cocoflavanols, which are viewed as the bioactive component in the cocoa bean and is part of this whole dark chocolate craze. So this will eventually, in the years to come, provide some interesting results too. But ultimately, you're always kind of in a catch-22. When you do these trials, if you show favorable results, people will be happy to highlight the strengths of the trial design and everything you did well. No differently than if you have unfavorable results that counter the conventional wisdom, people will complain that your trial is basically a load of you-know-what, and you didn't do it right, and the design was wrong, and there are inherent problems. So you're doing these trials, there's a bit of a leap of faith. They have to assume that these trials are going to at least represent steps forward. It's not the final word. And finally, when we think about dietary supplements, we need trials of all sizes and shapes. Not just the large ones, but we also need the small ones. And trying to patch these together to come up with a cohesive understanding of exactly whether or not a dietary supplement does or does not have any degree of efficacy or effectiveness. And I think that there will always be new supplements that are coming out that are viewed as promising, so there will be no lack of opportunities, hopefully, for new research projects to get involved in. But it's also to think about that methodology. Who is the representative population? Do you have a way to recruit effectively? And do you have an intervention that you believe in, as well as intermediate outcomes to help to capture the mechanism of effect that might be in place? And while the large-scale trials are certainly a big undertaking and they require a lot of coordination across all sectors, they're hard to initiate, but they're still critically needed. And we'll see in the years to come what these trials will ultimately show. So thanks for your attention, and I'm happy to take any questions if we have time for it. Yes.
Great talk, thank you. What about the nocebo effect, people getting harmed from placebo? Do you see that?
Yeah, that's an interesting question. I like to say that the placebo effect is real. It's one thing that we have not fully utilized our trials to see to what extent the placebo effect takes hold. What's interesting is that, at least in the trials that we've done, we always have what we call a placebo run-in, where people start to get pills, and we use a 3 to 6 month placebo run-in to ensure that the people who ultimately get randomized are people who are compliant. A lot of times you can start to take pills and then you realize immediately, I don't want to do this, or it's too involved. But what's interesting about it, and something we haven't really delved into, is that everyone's taking placebo. So we, in essence, have a mini trial testing a placebo in everyone. And you'd be surprised what types of feedback we get from participants claiming that, gosh, I started taking these pills just in 2 weeks and my skin is clear and I have more energy. And so it's a real effect. We haven't quite captured it in our trial data yet, and it's something that we would certainly be interested in doing.
Could I just ask a follow-up on that? Since you're involved with cardiovascular disease, I've been reading about statins and CoQ10, and just what I'm sorry, it's not coming to mind, but I know. Yeah. Do you comment on that?
Yeah, CoQ10 is a supplement that a lot of cardiologists and physicians will swear by for kind of serving as an alternative to statin use. But the problem with CoQ10, which is the case with many other dietary supplements out in the market, is that there have been a lot of very small focus trials that have looked at the effects of CoQ10, but nothing that's really even come close, in my view, to coming to a point where making conclusions about true efficacy or effectiveness has not really happened. There's really no long-term, larger-scale trials. I'm not saying it has to be 10 years in duration, but there's been very few definitive trials on that product, as well as what the potential interactions and side effects might be with it. It's a very expensive supplement, too. Yeah.
Our center has some people with experience around, but we might try a combination of a couple of dietary supplements for a condition. Is it common practice to start with a case series or case control study before attempting a small-scale trial, or can you go for it with the right mentorship?
I would always say any data is better than no data. So if you're going to be seeing, whether it's through a case series or even a very small, any data are better than where we were before. Particularly, and I think it's especially challenging given the fact that no one tends to take just one supplement. People tend to take a supplement in combination with other supplements. Now that makes it harder for us to study it, whether it's in a case series or in a small clinical trial or a larger one, because you're trying to isolate the effects, ideally, of a particular supplement. But to me, I think there's a general lack of data on dietary supplement use and its health effects or even its mechanisms. So I would certainly encourage those types of work to be done.
Great, thank you.
Yeah.
How do you pick your doses?
It's a really tricky process, and you'd be surprised how challenging it can be. Just as an example, for the VITAL trial, we ultimately wound up at 2,000 IUs, but in truth, that dose or amount actually kind of crept up over time in the design phase of it. There's no perfect answer to it. You can argue that if you're doing a vitamin D trial, the perfect world will be one in which you test what people are commonly using. So it might be 1,000 IUs, 2,000 IUs, and perhaps 3,000 or 4,000 IUs, although that starts to get close to the upper limits that the Institute of Medicine that would necessarily recommend. The problem with that type of an approach is that it requires more people, longer follow-up, more outcomes. And so ultimately, you have to kind of take a leap of faith at a certain amount of a particular nutrient and go for it, hoping that the science won't change tremendously by the time you publish it. We could start with 1,000 IUs D. 5 years later, everyone's taking 2,000 IUs. You have a trial result that's interesting, but doesn't really reflect current clinical practice or practicing. In the back?
In the VITAL trial, how are you planning to control for geographic differences?
Very good question. We know that obviously D is the sunshine vitamin for a reason. The lower latitude, the better off you are in terms of at least getting potential sun exposure. What's nice about the VITAL trial is when it's a randomized clinical trial, randomization inherently will control for geography and latitude. So if you were to look at the VITAL trial participants and separate it by latitude, because we're randomly choosing who in the room is going to be taking the active or placebo, it is equally distributed, I should say. That being said, what's an interesting subgroup analysis that ought to be considered is one in which you look among those people who are at higher latitudes, whether it's over the 37th parallel or not, and compare it to people who are at lower latitudes to see if supplementation might be perhaps more beneficial among those who at least have a greater opportunity for sun exposure or not. But of course, there's more factors. It's not just whether you're living in Florida, but whether you're actually outside playing tennis and walking and doing other things too. Yeah.
How do you measure compliance in these trials, the male trials?
Yeah, good question. It's a bit of a leap of faith. So because they're male-based trials, we're not seeing patients directly. We're sending them calendar packs that they receive, and then they get questionnaires periodically sent to them that will ask them to report approximately how many pills on a percentage basis or a numerical basis are you taking each month. So it's not as good as doing a smaller clinical trial where you have some of the pill bottles that you can open and close and the chip counts it, but that still is not a perfect measure of compliance either. So it's based on self-report. We do complement it, for example, in the VITAL trial and the other trials that we do collect bloods both at baseline and at follow-up in VITAL, as well as in the Cosmos trial, where we can track some of the key biomarkers and other markers of compliance that we believe ought to be linked with taking the active versus the placebo. So that's a second layer through which we can verify the compliance that they're self-reporting. But we do believe it tends to be good. Not perfect, though. Sorry.